all been an excellent audience. A big clap for all of you. Amazing. You know, this is the first time that I have seen everyone staying on towards the fag end of the conference. So guys, you're great, you rock. So standing between your home, sweet home, and the conference is just me and the nerves. So would you want, I will just show 6 slides. We are dealing with upper extremity nerves. I was not too sure when they said nerves. I just prepared upper extremity. If the time would permit, I will quickly show you. But this is something which is like, each one of us has been feeling that radiologists are perhaps losing out to one group of consultants, and that's the anesthetists. That's one place where we radiologists are, I don't know whether it's our little fear of the needles. You know, वो सर्जन आता है, कहता है liver abscess tap करनी है, सुई वो डालता है, हम दिखाते हैं, X into 10 amount of money वो ले जाता है, X minus 1 हम रखते हैं. So I feel that there is definitely a hesitancy in the radiologists to stick in the needles. And that is one part where the pain management guys are really, I know of a lady and she started learning about 4 years ago. She went abroad and the way she puts interscalene blocks. You know, like, it's like she just holds the probe, she sees, बात करते करते वो interscalene लगाती है. मैं सोचती हूँ radiologist लगाएंगे कि नहीं लगाएंगे, I have no idea. So that's the only reason why we thought we should be talking about nerves, and I think we should lose this fear of, I'm sorry, yeah, we're back again. So that's the only reason why I'm on to nerves. I will show you precisely 6 slides. I won't really go beyond that so that each one of you can go back home and your spouses will not be fighting with you. And then in case we have some time, then tomorrow we can go for a live demonstration because we really need to be concentrating on what we are talking here. Okay, so this is just a review. Upper limb nerves, we are talking about brachial plexus. And brachial plexus, I'm sure each one of you knows. I am just going to go with a very short review. Can I have a pointer, please? Yeah. Is this a pointer? Oh, yes. All right. So we are talking about the brachial plexus. Brachial plexus, anyone? C5, C6, C7, C8, T1 nerves. Each one of us knows. And there are distributions, which are distributions starting from roots. Then we have the trunks. Then we have the divisions. And we have the cords. And then we have the peripheral branches. Now, these distributions don't have any functional application. They're just so that we understand where what is coming into the anatomical region. So when we are talking of roots, we are talking of C5, C6, C7, C8, T1. These are the roots, okay? And C5, C6 combine to form a superior trunk. C7 continues as the middle trunk, and C8 and T1 forms the inferior trunk. So we have 3 trunks, superior, middle, and inferior. Now, these actually go into another region, a little posteriorly in the posterior triangle, and divide again into anterior and posterior components, which are called as divisions. So out of 3, now we've got 6 divisions, and they look like a bunch of grapes. We'll go on to explain to you. These divisions then continue into the infraclavicular region, where they again reorganize to form 3 cords, medial, lateral, and posterior, which continue into the peripheral nerves. Are we good with it? Lovely. Even if we are not, you go back home and study. Okay, so I go on to my next slide, and this is how we go on. This is probably the first step of starting. And how do we start? We will talk about the landmarks, but we have our carotid artery. You have the internal jugular vein. In between the two, you see a small speck here, a hypoechoic area. That's our vagus. So I'm sure each one of us has seen this enormous number of times when we are doing our thyroid scans. But we miss out in this small little thing, which is the vagus. And if you will just move your probe tomorrow, if we have the time, this vagus moves in and out very beautifully. As we move posteriorly and a little superiorly, do you see this? So that part and that part. So this is the groove in which the roots originate. And this is the posterior tubercle of C6 and the anterior tubercle of C6. C7 vertebral body does not have a posterior tubercle. So now when we are dealing with the tubercles, we are really happy to see the root here. Okay? This is again, you can again see the posterior tubercle, anterior tubercle, and the root very clearly. It's just I have optimized my image through toggling of my probe. Again, the carotid artery, and we go posterolaterally to just see this structure. If I just make this movie run for you, is it running? Ooh la la la. Is it running? Yes, it is. So what we have here is our thyroid, the lateral lobe of the thyroid, carotid artery, internal jugular vein, small vagus, and of course that will in turn, when we move down and distally, the subclavian artery. But as we move, can you see that? That's the clinoid. Those are the tubercles of the vertebral bodies from where, when we'll optimize, we will see our roots coming out. These are again the same optimizations. So these are the landmarks. This line that you see is the pleura. We should always be able to see it because we need to give in an interscalene block. These are the organized. This is how the roots are going to get formed into the trunks. First rib and the prevertebral fascia. That's the prevertebral fascia, which needs to be pierced in order to reach the interscalene region between the anterior and the middle medius scalene muscle. So I'm just going to go over, stop my video here, and we go on to the first of the trunks. So we have a superior trunk, and we have a middle trunk, and then we have an inferior trunk. This is with C5, C6, C7, C8, and T1. This is exactly where we'd like to put in our needle and put the interscalene block between the medial and the anterior scalene muscle. And that small speck, which has got overlooked by this small triangle, is our phrenic nerve. So most of the people, or most of the anesthetists, are really wary of going into this region because sometimes when you've given a block, you actually paralyze ipsilateral diaphragm. So when we are talking of ASA3 and ASA4 type of patients, a block of the phrenic sometimes can be catastrophic. So we really don't want to give in our interscalene block to ASA3 and ASA4. We go on to give, and this of course is a diagrammatic representation, which we have seen. However, we are very happy in the supraclavicular or in the infraclavicular region where the divisions get formed. So that is kind of like bunch of grapes, or some people call it the end on straw sections, yeah. The probe orientation for the suprascapular divisions is just parallel to the clavicle. This is of course a cadaveric image, and this is a diagrammatic image. So from the interscalene, that's the red part, that's my probe orientation. My anterior scalene muscle, medial scalene muscle, in between, it also is called as the traffic light signals, superior, middle, and inferior. That's how we give, and of course you can see the thyroid here. I'm sure you can see the thyroid here, and you can see the carotid artery, and you can see the internal jugular vein. So we've gone posterolaterally, and we see our three trunks, superior, middle, and inferior. And that is, as we go inferiorly, is the bunch of grapes or the divisions. So that is my interscalene, and this is my bunch of grapes where I'd really like to go. Last but not the least, in the infraclavicular region, and my landmark is the axillary artery. And this axillary artery, this is a extended field of vision view here, a panoramic view. We have the three cords. We have the medial cord. Medial cord gets extended into the ulnar nerve. And then, of course, we have the median nerve. And this is the lateral cord, that through the lateral cord, we have the musculocutaneous nerve. And then there's a posterior cord, which makes the axillary nerve and the radial nerve. So once you come here, If you can see my probe orientation and the position of the arm, just as you put it here and go through an extended field of view or through a panoramic view, you'll be able to see your ulnar, median nerve, and musculocutaneous nerve, and the axillary nerve is a posterior branch. It goes posteriorly, enters into the quadrilateral space. So that, in short, is what the upper limb nerves are. And then, of course, you can trace it. Dr. Amit traced it very beautifully. The median nerve, he started tracing from the cubital fossa and went down to the carpal tunnel. And that's how we do it in short axis. You go in, this is called as a lift or an escalator technique. You move your probe from cranial to caudal, or from caudal to cranial, or to cranial to caudal in a short axis. Don't lose your landmarks. Pick up a landmark that you're familiar with. You really don't have to go from the axillary region and keep tracing that nerve, and you lose it and you say, oh my God, I've got to go back up again. No, there are landmarks. For the median nerve, we all like to choose either the carpal tunnel, and we go in a lift manner and go up and trace it right to the axilla. For the ulnar nerve, we have our cubital tunnel. We trace it from here. Go into the distal region or go into the proximal region. For the radial nerve, we have our radial groove. We are very happy to trace the nerve from the radial groove up into the axillary region, or down, coming anteriorly into the cubital fossa and going down into the palm region. So that part, or the dorsal region, radial, doesn't go into the palm, it goes on the dorsum of the, and musculocutaneous nerve then becomes the musculocutaneous nerve of the lateral cutaneous nerve of the forearm. So that's, in short, nerves. I hope they weren't too big. We can always do early morning. We start at 9. So if you all are fresh, we could do just a short live demo. Thank you very much. Great being here today. Thank you. इसको ज़ूम करोगे? this is the insertion of the iliotibial band right here. But as we go posteriorly, we see for the head of the fibula, and this part that you see a bit anteriorly is the insertion of the lateral collateral ligament, and as we go a little posterior, we see for the insertion of the biceps femoris tendon. That is the biceps, long head of the biceps femoris tendon, because if we proceed cranially, what we see is that the lateral head, the long head of the biceps femoris, right there, getting converted into a tendon and taking its insertion on the fibular head, taking its insertion at the fibular head there. So from here we go on to the posterior evaluation, and we just kind of increase our depth here. ऐसे घूम जाएगा. Normally it should be, he has swelling on the other side, so I'm going to, when I'm going to turn him over for the other evaluation, so we have a short axis scan. The first is a short axis scan, and the short axis scan, what we see for is the deepest. Of course, color Doppler always helps. So as we put the color Doppler, we see the popliteal artery right there, and if I lose the pressure, I can see the popliteal vein. So as I put on the pressure, my popliteal vein disappears, and I think each of us as radiologists don't need to talk about that. And just at the level of the, as I go superiorly, the honeycombing pattern that you can see superficial to the popliteal vein is that of the tibial nerve. Yes, right there. So that's the tibial nerve. And as we proceed even more cranially, we are able to see the two bifurcations. The two bifurcations, I'm going to put the color off from here. And as we see for the sciatic nerve, and that's the sciatic nerve. And as we proceed down, we can see it getting so that's where it splits into two. Yeah, it splits into two. There is one sciatic nerve that we can appreciate. So, yeah, so right here. That's sciatic nerve. And as I go, proceed distally, it splits into two. Right here and right here, the common peroneal and the tibial. And the common peroneal and the tibial. Moving down, this is what we are taking down as tibial. And if we put the color Doppler on, we can have the tibial and the vein and the artery. So that's the part of it. For the posterior cruciate, we'll need to really put him in an optimal position. I'm just going to try to see medially if I can. That's, of course, the posterior horn of the medial meniscus can be seen. And we could have done it at the time when we were scanning the anterior horn, but now we can do it as posterior horn. And this is the posterior horn of the lateral meniscus here. So the posterior horn of the lateral meniscus in a long axis scan, and that's the posterior horn of the. So this actually gives, and this is an important landmark, because this is where we again see for the osteochondral injuries, because you can see the cartilage that is lying just underneath, covering the femoral condyle. So this cartilageous injury can be very well picked up and documented on an ultrasound. So this is an important part, and in the same manner, the cartilage evaluation on the lateral femoral condyle can be seen, since it's covered by the cartilage and can be seen very clearly against the contrast of the fibrocartilage of the lateral meniscus. So with this, of course, the more important part is, I'm really sorry because I'm not putting him in an optimal position, but I will, and that's the time we will talk about the the place from where the Baker's cyst emerges. So it's something which comes between the medial head of the gastrocnemius. So that's the medial head of the gastrocnemius. And as I come a little more medially, the tendon, yes, the semitendinosus, the semitendinosus tendon right there. But a part of the muscle of the semimembranosus is seen. So in between the semimembranosus and the gastrocnemius, medial head of the gastrocnemius and the head of the semimembranosus. This is the area from where the Baker's cyst emerges. So that what we see here is the belly of the semimembranosus and gets converted into a tendon. And what we see here is the lateral head of the medial head of the gastrocnemius. So from here, I'm going to go on to the pathology with which this gentleman is presenting. As you can appreciate, if you can see clinically, there is a lot of swelling of the knee joint, and the joint and it looks as if there is an inflamed soft tissues, or maybe the joint that is sitting here, as compared to the superficial. This is the normal prepatellar region I'm showing. Normal prepatellar region. So that's the patella, and the prepatellar region that you can appreciate here. The reasons why we are getting that very bad image is, so I mean, this is something which the bad image is because there is not enough gel and my probe is not in contact. So if you can just see that image, and we are going to remove that by keeping a good gel pad. So now you can see that those reverberations that were coming in the left side of the screen have disappeared. So to make an optimal image, that is the prepatellar region, and this is a normal prepatellar region. Can we have a split screen image, please? No, split, dual, perfect. So I'm going to freeze this here for you, and I'm going to come on the other side, and if you can see that underneath is the acoustic margin of the patella, and you can see the soft tissue that has increased in depth. There is effusion there, there is a lot of debris there, and if I press this region, I can see that it is compressible but not entirely displaceable. Now that is a very important feature, because if this would be just free fluid, it should have completely got displaced. But despite my great probe pressure, I'm unable to actually displace out those hypoechoic image that you are seeing. And that brings me to a thought that, are we dealing with synovitis in this region? That there is, yes, so we are lifting a lot of vascularity. So this is not only that we are having a prepatellar bursa effusion, but we are having prepatellar bursitis with synovial proliferation. And that's the reason why we were unable to completely displace out that fluid. A clear fluid would always be very happily displaceable and compressible. This is compressible. I can compress it, but I can't displace it. Why? Because there is a lot of synovitis. So one thing is sure, that we are dealing with a prepatellar bursitis with synovial proliferation, and this could be secondary to hemorrhagic changes that could have come. You could always also appreciate how the subcutaneous tissue thickness has increased, which could again be reactionary. As I am going and evaluating all the subcutaneous tissues first, I can see that there is a lot of edema that is present on the medial side. Those are the edema changes of the subcutaneous tissues on the medial side, because if I go on the ipsilateral asymptomatic side, this is how we are able to appreciate the subcutaneous fat and the interfacial planes. But if I come to the affected side, I'm going to freeze this for you, and I'm going to go again to the other side, and defreeze, you can appreciate there's a lot of edema. So the entire subcutaneous tissue planes have got blurred. There is a depth that has come, and I can also feel that this is a prepatellar bursa. So now we are going to evaluate, is there an intra-articular pathology, because there seems to be a prepatellar one, and I'm going to just optimize the position of the patient. इस वाले को भी fold करेगा, wonderful. And what I can see here is that the normal curvature that usually you find of the quadriceps tendon, it's become concave. There is no convexity here. It's a concave concavity with kind of, this is again the symptomatic side, and this symptomatic side I'm going to freeze for you, and I'm going to go to the asymptomatic side, and I'm going to freeze this also for you. And so this is there a change that you can see between the two? No, none at all. So I'm just going to come and evaluate the quadriceps tendon. Yeah. So we're going to just evaluate our quadriceps tendon. We're going to go to the musculotendinous junction. And in this musculotendinous junction, I'm coming distally to see for the tendon, and that tendon doesn't show any tear. It is well defined, well demarcated. Long axis scan. I'm again traversing that caudally, and what I see for any tears, I'm sorry, the gel has finished, so that's the reason. I apologize. And as we're scanning the quadriceps tendon, that's the quadriceps, and it doesn't show any tear. In fact, it doesn't show any effusion also. You can see the S shape of the suprapatellar bursa. There's not an effusion. We are just going to be extremely cautious, and what we didn't talk about in the presentation was that sometimes the effusion, if it is not in the suprapatellar region, it comes into the deepest recess, and that deepest recess is the lateral recess. So the lateral recess also doesn't show effusion. In a short axis scan, we actually come to the midline and take our probe all the way laterally. So in the lateral recess also we don't see any fluid. In a similar manner, to again unearth if there is an effusion, we again come to the medial recess, and in the medial recess also there is no fluid that we can talk about as an intra-articular effusion. And as we go on the medial side, go all the way from the joint line. If you remember, we were talking about that, is there a loss of cartilage on the medial side? And as you can see here, that's the joint line that we're seeing of the symptomatic side. I'm again making dual for you. I'm so sorry, dual. Right, so I'm going to freeze this joint line for you here, and I'm going to go on the asymptomatic side again for you. And this is the joint line of the asymptomatic side. So you can see the cruciate here clearly. There is a minimal loss of the thickness of the cruciate on the symptomatic side. So we are going to talk about again the symptomatic side. Is there a tear of the cruciate? There seems to be an extrusion. It seems that the medial meniscus is extruding. It is actually not flush with the margins of the femoral and tibial condyle. They're just a little. कितना दिन पहले आपको ये चोट लगी थी?
ये चोट लगी 10-12 दिन हो गए.
अभी सिर्फ 10-12 दिन हुए हैं.
हाँ.
उसके पहले भी कभी चोट लगी थी आपको?
नहीं, पहले
नहीं. ठीक है.
ये पहली बार.
So, the medial collateral ligament, the hypoechoic thickening of the medial collateral ligament, that's the medial collateral ligament. And I'm going to freeze this for you. Go back again to the, I'm so sorry, I'm a little not used to this machine, the tool, right. Okay, and we are going to see for the medial collateral ligament. So, come back here, and I hope that you can remember the medial collateral ligament on this side, which is showing altered echogenicity. The fibula pattern is lost, it is thickened, and you can see that there is a little extrusion of the medial meniscus. The joint space appears to be reduced, not that there is any osteophytosis, but as I come to the asymptomatic side, I am in the line of the medial collateral ligament. That part is Dr. Pippin said, does it look as if there is, yes, an osteochondral body that is coming out of the tibial right here? That's the femoral condyle, sir. Yeah. So I'm at the tibial end now, where there is an attachment of the medial collateral ligament. Right here.
So
this is a tibia. Yeah, this is tibia where there is attachment of the medial collateral ligament. Does it seem that there is a little avulsion chip coming from there? Not that. Irregularity. See, because this is just the thickening of the medial collateral ligament, so I'm not truly convinced about that one. If I just turn him around and go over, this is the lateral evaluation of the symptomatic side. So that's the lateral meniscus is well maintained here. You can see the meniscus in its form and the collateral ligament. There doesn't seem to be a tear. आपको सबसे ज़्यादा दर्द किधर है? घूम जाइए उधर, उस साइड में ऐसे घूम जाइए. You can ask the patient to take a turn and flex the knee joint. So this is the long axis. What we are doing is the long axis for the iliotibial band. So we can see the iliotibial band, and underneath is the vastus lateralis. As we go distally and cross over, it takes its insertion. Yehi dard hai. The point tenderness does help to regulate our direction of where we want to evaluate and have a focus scan. This is the iliotibial and iliotibial band, you can see right there, and taking its insertion at the Carotid tubercle. So the iliotibial band is kind of intact. There is no loss of echogenicity. So we are good with the iliotibial band. We come to the joint line, and against the joint line, we look for the what we are seeing here is the proximal end, the proximal region of the femoral condyle. We have tibial condyle, and then we have head of the fibula. What we see in the middle is the proximal tibiofibular joint, and he gave a point tenderness at this level. This point tenderness is There appears to be a little bit of a loss of the fibular pattern of the attachment of the lateral collateral ligament, but now he is comfortable. ये तो आपको दर्द नहीं है ना? नहीं है ना? ये दर्द आपको ये है, हाँ? यही है. So he is continuously pointing to the prepatellar region, along with, if I go posteriorly, this is the insertion of the long head of the biceps tendon. There is no tear at this point. Collateral ligament, no tear at this point. And we come to the attachment of the iliotibial band, and he's good on the lateral side also. Cruciate here, popliteus tendon, lateral collateral ligament, which is not showing any tear. Posteriorly, if I go and assess, I have good distinction of the interfacial planes. That is the lateral cruciate, lateral meniscus. Why do I keep saying cruciate? I'm in love with cruciate, it seems. Anyhow, so that is the posterior horn of the lateral meniscus, and you can see very clearly there is the cartilage of the femoral condyle. Again, the posterior horn of the meniscus. Again, the posterior horn of the meniscus. And if I go medially and try and see in my short axis, is the medial head of the gastrocnemius tendon right here. So in between the two, we have, you can see actually the continuity, how the Baker's cyst would come and sit there, just in case there is one. So there is hardly any reason for us to think that there is a posterior pathology. So by and large, what he has is a prepatellar bursitis with synovitis, which is giving inflammation to his entire knee joint. And thank you very much.